Welcome, everybody. Thanks so much for joining us. We're going to get started in just a minute. Thank you, everybody who has joined us today. We're going to start in just a minute. We're just going to give folks another minute to log into the webinar. We're super excited that you were able to join us. Okay, I think we're going to get started. Thank you all for being here today. Just a quick note, we are recording this webinar and we will be sharing the link. But we're really grateful for all of you who have decided to join us for this next hour to talk about CalAIM. My name is Carolina Reed, and I'm the Faculty Research Advisor with the Terner Center for Housing Innovation. We have a terrific panel lined up, and I'm really excited about today's conversation. I want to start by first thanking the California Healthcare Foundation for supporting the work we're doing to strengthen collaboration between permanent supportive housing and the healthcare sector. I also just want to take a minute and acknowledge their broader contributions to the field. I think the California Healthcare Foundation has done more than any other organization in the state to really expand resources on CalAIM. I would love to point you all towards the online Medi-Cal Academy that was run by the Corporation for Supportive Housing, the other resources that California Healthcare Foundation has on their website. All of those resources are just critical if you want to learn more about CalAIM. In my remarks today, I'm going to start with just a very brief introduction of why we're hosting a webinar on CalAIM. Our work on CalAIM started with our research on the state's efforts to build more permanent supportive housing, with initiatives like HomeKey, but also with funding programs like HAP and No Place Like Home. The state has made incredible strides in expanding the supply of permanent supportive housing over the past few years. These efforts are critical, as PSH is an evidence-based model for addressing chronic homelessness. But in every study that we did, we kept hearing a recurring theme. We may be building the units, but what we need is increased funding for the supportive component of permanent supportive housing. Residents need stronger supports to be successful, especially if they have more acute mental or physical health needs. But we continuously heard, and I quote, "We just don't have the financial resources to staff the properties at the levels we need." Partnerships with the healthcare sector are one way to build that support. Trying to bring together these two very complex systems, affordable housing finance and healthcare, isn't easy, but the promise is enormous, and that's where CalAIM fits in. It's important to say right up front that CalAIM is often used as shorthand, but the initiative is complex and goes much further than just housing. I'm still learning all the acronyms and regulations. What we are focused on here today is a very specific aspect of CalAIM. Through a Medicaid waiver, managed care plans, the entities that help to provide healthcare to millions of low-income Californians, can reimburse providers for community supports that address the social determinants of health, like housing. In a minute, Tessa is going to describe these community supports more. But in the third quarter of 2024, nearly 50,000 people received either housing navigation, housing deposits, or housing tenancy supportive services, all paid for by the healthcare sector. Our goal with this initiative and what we're doing with this webinar is to increase the availability of these resources for people experiencing homelessness by helping to educate housing providers about CalAIM and showcase how housing organizations have successfully navigated implementation barriers. We're delighted that you have all joined us here today for this panel conversation. Oops, there we go. We're going to start with a brief overview of CalAIM and the work of the community of practice, presented by Tessa Nápoles, a postdoc with the Terner Center for Housing Innovation.
Thanks, Carolina.
Oh, you're not quite ready yet. You don't get to go quite yet.
Okay.
We'll then talk with a panel of experts to get their insights. And just a bit of housekeeping. We will have some time for audience Q&A. So please put your questions in the Q&A box and we will get to as many as we can. We are also recording this webinar and we'll make it both it and the slides publicly available. Tessa, I'm now turning it over to you.
Thanks, Carolina. I was very eager.
That's great.
CalAIM, which stands for California Advancing and Innovating Medi-Cal, launched in 2022 as a 5-year initiative designed to re-engineer Medi-Cal. Medi-Cal is the state's Medicaid program, which insures nearly 15 million Californians, or 40% of the state's population. The primary goal of CalAIM is to improve health outcomes for people with the highest service needs. As Carolina mentioned, CalAIM entails a much broader set of reforms to Medi-Cal than we'll be able to talk about today. So for the purposes of today's conversation, when we talk about CalAIM, we're going to be referring to the Housing Trio community supports, which includes housing navigation, move-in deposits, and what's called housing tenancy and sustaining services, or HTSS for short. We also wanted to note that some providers are enhanced care management, or ECM, entities, and they deliver coordinated care to residents with complex needs. And while some of our panelists are ECM providers, we're going to focus this webinar largely on housing tenancy and sustaining services, or HTSS. So why does this alphabet soup matter for housing providers? CalAIM unlocks a new funding channel for permanent supportive housing providers by allowing them to tap into Medi-Cal resources. Anyone who runs PSH knows the importance of the S, the supportive services, in keeping people housed over the long term. As it turns out, many housing providers do HTSS all the time. For example, they're involved in the early identification of barriers that might impact housing. They're helping residents communicate with property management. They provide benefits assistance and navigation, lease compliance, and health and safety visits. Unfortunately, though, traditional housing subsidy programs often don't provide enough funding to cover all the supportive services that residents need. And this funding is especially crucial for serving individuals who have experienced the trauma of long-term homelessness, which is often paired with unmet mental and physical health needs. So using Medi-Cal dollars to fund HTSS enables providers to hire additional staff, and as Carolina noted, it holds the promise of providing long-term, sustainable funding for supportive services. Even so, understanding Medi-Cal, working with managed care providers, and developing a strategic plan on how to provide HTSS to residents is not easy. Housing providers face several significant challenges when implementing CalAIM. There's a lot of new terms, partners, and rules to understand. Different counties and health plans often use separate systems that don't work well together. This leads to problems like extra paperwork, difficulties sharing information, and slow billing. On top of that, confusing rules and changing policies, such as who qualifies for services and how providers get paid, creates a lot of uncertainty for housing providers. And so fixing these issues is really important if we want to provide personalized care as intended under CalAIM. It's also important to acknowledge that the uncertainty over Medicaid funding at the federal level, and the possible expiration of the Medicaid waiver that allows for community supports is also a potential barrier to broader implementation. At Terner, we've been organizing a community of practice with affordable housing developers to help understand the barriers of CalAIM implementation, as well as identify successful models. We've learned that CalAIM can make a huge improvement. It can improve resident engagement by requiring regular and intentional in-person check-ins, which allows staff to identify resident needs early, build trust, and provide tailored services. One case manager we spoke to shared, "Just seeing the value of more one-on-one time with residents who need a little bit more support, the opportunity CalAIM provides to prioritize them. With the CalAIM program, it has helped us pivot towards those residents who are more at risk of becoming or being unstable in community housing." Managed care plans are also starting to see benefits. We talked to a managed care plan representative who shared with us, "Initially, some of the return on investment data was not promising. But to me, that wasn't surprising. This is a very long game. Housing someone today is not going to mean they don't get hospitalized tomorrow. But we are seeing that at month 12, 18, there's been a decrease in costs. It looks to be trending downwards in things like emergency department encounters and in inpatient admissions, both of which are good. These improvements not only stabilize residents in their housing, but also help clarify staff roles and boost accountability through better resource access. Housing developers and operators are using flexible staffing approaches to tackle the challenges CalAIM brings. For example, organizations like RH Community Builders and Jamboree Housing aren't just offering community support services to their own residents, they're providing services to residents in the broader community too. And this is a bit different from how many PSH developers see themselves, in that it's more common to provide services only to their own residents. But having staff support community members outside the property increases the scale of people served and can increase funding predictability from Medi-Cal reimbursements. Providers have also found creative ways to handle the complex legal and privacy demands introduced by CalAIM. When an organization provides healthcare services, those services fall under HIPAA, which is the federal law protecting people's medical information. It's hard for housing developers, who collect many types of resident data, but not always sensitive health details, to build systems that meet full HIPAA requirements. And so MidPenn Housing has been innovative by classifying resident data into one of three HIPAA categories, depending on the specific service provided. For example, HDSS services provided by a case manager to a resident are covered under HIPAA, but if they're helping that same resident with a property management issue like a lease violation, HIPAA doesn't apply. And so this flexibility lets MidPenn kind of dial in privacy safeguards when they're needed without bogging down daily operations. Housing developers are also working to make their operations run more smoothly by simplifying billing and paperwork. So for example, Jamboree Housing has partnered with other organizations in Orange County to establish a new nonprofit called Housing for Health Orange County that serves as the bridge to the managed care plan and handles all of the back office billing. At MidPenn Housing, which works across multiple counties, they've applied the most stringent managed care plan standards across all of its properties, which simplifies claims management and reduces administrative burden. And finally, housing developers are strengthening their partnerships with managed care plans and healthcare organizations. For instance, Homeward Bound of Marin is working closely with Partnership Health Plan, the managed care provider in Marin County, to put CalAIM into action. Partnership Health Plan has been flexible with reauthorizing services for residents in PSH. It's also important to note that engaging in CalAIM community supports isn't about doing it all in-house. It's a chance to collaborate with partner organizations that offer specialized care. For example, Homeward Bound of Marin has also teamed up with Marin Health to support shared clients, helping them avoid unnecessary trips to the emergency room. So these collaborations lead to better coordination and accountability, benefiting both providers and residents. All of these strategies and more details on each are going to be published in a series of case studies over the coming 6 months. Our very first case study on Mid-Penn housing will be released in early May. And in this webinar, we've brought together a panel of speakers to help preview some of the lessons and strategies that will be highlighted in those case studies. Carolina, back to you.
Thanks so much, Tessa. I'm now excited to introduce our panelists. Swamini Bajpai is a CalAIM strategy and operations consultant. With a medical background, Swamini has supported the rollout of CalAIM across various affordable housing organizations in the Bay Area. Chris Kuntz is the Program Director of Housing and Homeless Strategy for Anthem Blue Cross California Medicaid Plan. He's responsible for supporting Anthem's housing and homelessness strategies for Medi-Cal members across 16 counties in the state. Frank Lopez is a Senior Program Manager with Jamboree Housing Corporation. As Senior Program Manager at Jamboree, he oversees the CalAIM program for scattered site and permanent supportive housing sites. And last but not least, Danielle McCluskey is the Senior Director of Resident Services at Mid-Penn Housing, where she oversees regional operations, partnership management, and health-focused programs. She's the business lead for Mid-Penn's CalAIM Community Supports Program. Thank you so much to all of you for being here today. All right, Danielle, I'm going to start with you. It's not easy to do this work. So could you just start by telling me a little bit about why Mid-Penn decided to pursue layering in CalAIM HTSS resources into your PSH properties?
Sure. Good morning, Carolina. Thank you so much for having me, and I'm excited to be here today to share a bit about Mid-Penn's CalAIM journey. So our engagement with CalAIM began in 2022. At the time, we were already involved in a few different demonstration pilots, including a whole person care pilot down in Monterey County and a community care settings pilot in San Mateo County. Unfortunately, the funding for these pilots was starting to wind down, as were some crucial services that were being provided by external partners. And so this situation kind of prompted us to explore other ways to continue supporting our residents. So ultimately, we decided to pursue credentialing with our managed care plan partners, Central California Alliance for Health and the Health Plan of San Mateo, so that we could become an authorized provider of community supports, and more specifically, housing tenancy and sustaining services. And we saw this as a way to continue to provide those essential care coordination and housing supports that our residents needed. Our initial enrollment strategy focused on residents that were participating in those pilots. So these were residents that were in permanent supportive housing or PSH set-aside units. And over the past couple of years, we've been able to enroll additional residents who reside in PSH units at different properties, including some upon initial lease-up. So they're moving in, and their first engagement with HTSS is with our dedicated team. We've also been able to identify and enroll residents who do not live in PSH set-aside units. So these are residents who are in project-based units or tax credit units who could stand to benefit from HTSS and additional supports. And we've been able to successfully enroll them in our program as well.
Thank you so, oh, sorry. Oh, no, I am not muted. Thank you so much. You decided, so you're talking about using these CalAIM HTSS resources for both PSH units, but also for residents who need more supports. But you haven't enrolled every single one of your residents into a CalAIM HTSS program. Can you talk a little bit about how you've been thinking about sort of targeted and growing your program slowly?
Yeah, that's a great question. I think if I had to characterize our approach to enrollment, I would describe it more as incremental and maybe a bit more cautious or pragmatic. So yes, instead of enrolling all eligible residents at once, we have focused on a smaller subset of residents at each of our participating properties. This could be as few as 5 or 6 residents at one property or upwards of 40 at another property. So this more gradual approach has allowed us to refine our processes, kind of build the necessary infrastructure, test some different staffing models, also while tailoring the program to meet the specific needs of our residents.
Great, thank you. Frank, I want to turn to you. Jamboree has also been sort of a first stepper into this CalAIM world. But you've taken a different model than MidPenn in that you're providing HTSS both for people within your properties, but also outside of them. Can you describe a little bit about how you're providing sort of the housing trio to both residents and members of the community?
Yes, of course, Caroline. Thank you for having me. I appreciate it. So obviously with the Jamboree services, we started the program when I first initially started with our homeless services. We were working with a provider in the community, working with individuals that were homeless, dealing with substance abuse, mental health, and we started providing those homeless services under our hub model with a small collaborative, other organizations with HHOC. And under HHOC, they were able to kind of guide us with the CalAIM program to start initializing the documents we're going to be using, the information that we're going to use for them to provide these services for them. So we kind of took that and started using it with these individuals at the facility. And from there, we started creating basically a case plan for them. We started doing screenings and providing information and providing that navigation for them as they were going out into the community and initially just being a bridge housing for them. Try to find something for them so we can find the long-term opportunity. We do in Orange County, we do have that housing first model. We're going to house somebody and kind of start taking care of everything for them at that aspect. But what we wanted to do is find a way to sustain that housing. And with CalAIM coming in, we were able to build that infrastructure of finding the right coordination and linkage to other organizations and to their Medi-Cal program. So we're looking at also at the whole person aspect of it. So we're looking at the navigation part, getting them document ready, getting them sustained to be able to find those outlooks and make sure they're ready to move in. And once they're moving in, providing a deposit, and then gradually going into that sustainability part. The sustainability part is the key program for us because as a team, we want to make sure we're providing those linkage to the community so they're supported and they're able to gain that. And obviously through that hub model, we get that guidance. So lots of times we're kind of overwhelmed with all the documentation and the paperwork, but HHOC guides us for that. So if there's any issues with the CalOptima and we're not meeting set criteria or we're not getting things done, they're able to guide us and say, hey, this is the direction we're moving. Kind of keep us in a straight pace so we're able to focus on the clients more and not on the document part of that. So once we build that infrastructure outside the community, we were looking at we can't get everybody into a PSH site. We can't get everybody a voucher. So we look at everybody in the same way. We're going to try to find new housing, and it's a scattered site. So we're going to look at everything. We're going to look at property management, private landlords. We're looking at everything, but we're providing that support step by step as they get there. We're not just going to have them housed and kind of walk away. We're going to be there to support them. And once we built that kind of structure, we were able to kind of layer it into our PSH sites. So our PSH sites, we already have that structure with our staff there, but bringing in the CalAIM component, we were able to now expand and provide those services at the site. So within our team, we offer housing navigation, deposit, and we offer the sustainability part, but we're also now able to layer the ECM program across outside the community and up to our PSH site. So it kind of benefits all our staff and all the individuals that we're working with.
Great, thank you. So Manny, I'm going to turn to you and I'm going to ask you to talk a little bit about how CalAIM works with managed care plans. And I'm seeing some questions in the discussion around, do nonprofits contract directly with the managed care plan? Do they work through a county or a Department of Homelessness? Do they work through a hub model like the Orange County model? Can you just describe this little ecosystem of managed care plans a little bit, and then how you would recommend organizations, or what's important for organizations to keep in mind as they are thinking about CalAIM?
Of course, I'm really excited for having this opportunity to share our learnings along the way, because that's the best form of learning, right? Peer education. I want to say every affordable housing provider who I've worked with the first question would be, should we get into this? And I would be like, yes. And so there are learnings for housing sectors to have about healthcare and how do you work with managed care plans. And to the questions that are in the chat, yes, housing providers will directly contract with the managed care plan. So they become the covered entity provider, which is again a contracting term. And they will be directly responsible for maintaining documentation, claims, and billing. And there's also additional hub models, one that Frank referred to. There's another hub model as well, where the county contracts directly with the managed care plan, just like Frank's also in another county that I've worked with. And then the housing provider works in contract with the county who helps with the administrative processes. So there are pros and cons, benefits and challenges, I would say, in working in any of these models. I would say for any provider looking to get into CalAIM and serving the residents, there is a lot of learning out there. So you would feel comfortable getting in it. And what are the things that you would need to know? So I wanted to highlight a few key factors that have resulted in effective managed care plan partnerships. And one of the first and foremost I want to recognize is the IPP funding, the incentive payment program plan that the managed care plans provide to community supports providers so that they could do infrastructure development, capacity building, staffing structure, trainings, figuring out their claims management system. So I really have my hats off to managed care plans to do that generously, because that comes up front, which is really big support for newly entering into these healthcare sectors. A few of the other things that I have found work very effectively is managed care plans attending path collaboratives where they're meeting their providers directly. So the resolution is also happening face-to-face, which I really find is great best practice. It's no longer a myth out there, oh, a healthcare system. It's really seeing them face-to-face and addressing them by name and what work that there is. There's also a lot of role clarity that managed care plans have figured along the way, where they have designated teams and staff members to address outreach, enrollment, claims, which is really helpful for community supports providers. And the problem-solving mindset, I definitely feel that is really critical. And I have seen both parties come to the table with the right attitude. We have this resident in mind. Let's see what we can do better for them. So I think that has gone a long way. Every systematic change has challenges. So what can we do better? So there are certain things with managed care plan and housing partnerships that I wanted to highlight that we would hope to see evolve over the next few years as well. And one of the primary things that I feel is critical is care planning. Managed care plan to me is a hub of all the care plans of different community supports providers, and how can we come together and get a better sense of the universal and holistic care plan for the resident. It helps in managing resources effectively and aligning all the pieces for the residents so that ultimately they stay housed, receive the best health outcomes, and continue to live long and have a better quality of life.
Thank you so much. And this is a great segue to Chris. You are at a managed care plan or managed care organization. You come from the housing and homelessness sector, and so you're uniquely qualified to be a translator here. What would you say is motivating managed care plans to do this? And what would you say to new housing providers that want to access or talk to their managed care plan or integrate CalAIM HTSS into their properties?
I think just from a state perspective, right? Department of Healthcare Services, they're really urging health plans and community-based organizations to get more of Medi-Cal members enrolled in these different community supports. So really the charge from the state is, hey, let's figure out how we get more people access to these services. And so little context, with Anthem Blue Cross, we're the Medi-Cal managed care plan in 16 counties in California, and that's so we have a fair amount of counties that are all unique, right? We have some kind of very big urban counties, Los Angeles and San Francisco and Santa Clara County and Sacramento, and And then we have some very, small rural counties, Inyo County and Calaveras County. So, we're really trying to think, how do we roll out these community supports with those local organizations and, tenancy supports and housing navigation deposits. That housing trio is critical to getting, our members who are homeless, off the streets, out of shelters, into housing. I think, on the tenancy supports in kind of specifically, we it's no shock that it takes an incredible amount of work to get people into housing, right? There's a lot of work. Housing is scarce across the state, urban counties, rural counties. So when folks do get into housing, right, we want to make sure that they're stable, that they can end their homelessness, right? They have some stability. They can receive the supports to remain in that housing for the long haul. And I think, some of the slides previously, right, showed some of the benefits of, keeping people housed and supportive housing with services. And yeah, that research is 10, 20 years old, right? So we know this stuff works. We know if folks get in and they have access to supports, they can be successful, despite, challenges that they might have. So. But yeah, I think we're just trying to continuing to build partnerships to get more of our members into these critical supports. I think what we've seen, at least at Anthem, is that housing tenancy and sustaining services continues to be one of our kind of most utilized community support. I think housing navigation, meals, and tenancy seem to be our most kind of used resources across all of our counties in California.
So I'm going to ask a follow-up question to you, but then I'd love to have other folks jump in. I think this question also came up in the discussion Q&A, is one of the big disjunctures is that HTSS is often authorized for 6 or 12 months, but most residents of permanent supportive housing or people with acute physical or mental health needs might actually need those services much longer. Chris, can you talk a little bit about how you think about these initial authorizations, reauthorizations, and then I'd love to hear from others about how you think about this with the context of your residents.
Yeah, and I can start at least from kind of what we do at Anthem. So yeah, I mean, I've worked in supportive housing programs, run supportive housing programs, so I know that folks that are getting into these units, they have long, history of homelessness. They have a lot of other, challenges in their life. They're going to need some support, not just on the housing side, but on the service side for a fair amount of time, potentially forever, right? And I think that's the type of population that Mid-Penn and Jamboree, those are the folks that are getting into their units, right? People with complex, conditions that need help kind of for a fair amount of time. So at Anthem, on our housing tenancy support services, we authorize for initial year period, and then we reauthorize on a 6-month basis, and then we'll continue to authorize people for these services as long as they, have the need. So we can kind of reauth every 6 months, right, after that first year. And I know sometimes that gets challenging on the providers, right? But I think we know that these folks will need supports for a long time. So we want to make them available as long as folks meet the criteria and that we've set and that the state has, and there's a demonstrated need. So but I also know that other health plans may do things a little bit differently. And I think that's I saw on one of the earlier slides on the kind of policy considerations, right? I think health plans, we do talk to each other a lot, and we try to align as much as we can, because we know some of our providers are not contracted with Anthem, but they might be contracted with 1 or 2 or 3 other health plans in a community. So as much as we can work together as health plans to kind of coordinate and align, I think that's we know that's better for the organizations that we're working with.
And I've also heard you say that it's also very important for people who are in your role within a managed care plan to educate the managed care plan staff about the fact that often people don't stabilize in just 6 months?
Yeah, we have an amazing community supports clinical team that works a lot with our providers, a lot with our members, and does all the referrals and authorizations, and they're amazing folks. I get to communicate with them all the time, so we're kind of constantly educating each other internally.
Great. And Swamini, did you want to jump in? Just I see a chat here. This is a world of alphabet soup. I can't even say it out loud, but HTSS stands for Housing Tenancy Supportive Services. So they are the services that a provider can provide for a member that helps them to sustain their housing. Swamini.
Yes, and I wanted to add that I have seen an evolution even within managed care plans in the past 4 years, where they have brought on changes for reauthorization processes, recognizing that these residents will need continued support. And what I've heard them often say is, give us a good context of what continued support they would need. And many times the resources that they receive from housing providers stabilize them, but that does not mean they graduate from the program. That just means we want to make sure we don't have one episode of decompensation happen. So what is it that the support system is looking like? So I would say that it's promising in the progress it's showing, and reauthorization is a healthcare term, the healthcare process. So how are we meeting it in the middle is pretty much how we're seeing it.
Right. Frank and Danielle, can you speak to how you have experienced reauthorizations for your residents?
Yeah, so one of the biggest things we do when we obviously meet an individual, we do an intake. We have a care plan and an assessment that we provide in the beginning and a screening. So once we start doing these, we start working with them, we try to see their growth. And during that process, we have case consultations between the staff and other providers to make sure that they're achieving their goals. And if they are achieving their goals, we're going to add a new goal. And basically that way, when we do reauthorization, we can kind of show the growth that they're doing or the needs that they still have to continue to do these authorizations. I know since we started the program in 2021, we actually have people coming in up to the 2-year mark of working with us still. And obviously there's been growth, but we know as an organization with the population we work with from the beginning, there's always been a lot of needs that need to be for their support during the present time as well, and the ongoing services that we can provide. So we don't look at it as like we just complete a goal, you're good to go. Is that we're going to continue to build on you to get to the point where we're not needed anymore. But obviously during that authorization process, we want to show the growth to CalAIM to show that that need is still there for them.
Great, thank you. Danielle?
Yeah, I think Swamini alluded to this, the language, the timeline, the approaches differ between affordable housing providers and managed care plans. And I think that just kind of represents this like operational kind of cultural gap that exists between these different sectors. But while, we've been successful with reauthorizations for our residents, one of the ways that we kind of think about this, and Tessa briefly mentioned this, is we try to standardize some of our internal policies. So when you operate either in a county with multiple MCPs or you're working with multiple MCPs across a geography, it can be helpful to the extent that it's possible to standardize your internal processes. So in our case, we've kind of implemented the most rigorous requirements across all of our partnerships. And so we had one managed care plan, for example, that mandated very specific and detailed outreach, documentation, authorization procedures, and we decided to extend those standards to our other managed care plan properties as well. And so that kind of uniform approach helped us by, not forcing us to tailor protocols for our operations, kind of reduce administrative burdens, especially for our site-specific, our frontline staff who are doing this work day in and day out, right? So, but I agree, there's been progress. Would love to see even more across our different partnerships.
And Danielle, I'm going to stick with you for just a second, because there's quite a lot of questions in the discussion around how this actually plays into the finances of an organization. I was wondering if you could talk a little bit about how this works as a reimbursement model, as opposed to a grant, which I think is more typical of housing organizations, but then also just give us a little bit of a sense in terms of what it contributes from a financial resource point of view.
Sure. So yes, it is a reimbursement model, and at MidPenn we're a little unique in the sense that we also have chosen to handle the claims management or billing process in-house. So we kind of have this like firsthand experience of navigating this new system involved in Medi-Cal billing. So essentially, kind of to quickly summarize, you enter into a contract with your managed care plan. You negotiate the rates at which you will be reimbursed, and that can vary across different managed care plans. So one managed care plan that we contract with, for example, pays us a per member per month amount that is standardized. We are contracted to provide the same type of community supports with another managed care plan, and the reimbursement rate is a little bit different, right? So it's going to be specific to the managed care plan. After you enroll a resident, there is a enrollment process and authorization process. Again, these medical terms, right? But the resident or participant has to be approved by the managed care plan to participate in the community supports program. Our on-site team will provide the services every single month to them. So these housing tenancy sustaining services, they will document the services that they provide. And ultimately that data is compiled, prepared, compiled, sent back to the managed care plan as part of a claims management process where it is reviewed, and then a reimbursement is sent to your organization. So it is a capitated payment model in our case. So per member per month, a flat rate, whether
What's
we interact.
capitated? What's capitated? It's not somebody being decapitated.
No. So this is a fixed amount that the health plan has agreed to pay us for the service that we're providing. So whether we meet with this individual one time in the month or we meet with them 20 times in the month, we are receiving a flat rate for the service that we provide to them as part of the terms of our arrangement. So we are paid back in this reimbursement kind of model. So is it enough funding to cover or completely offset your staffing or administrative costs? Probably not, at least not initially. It really depends on the scale of your program, your staffing model, which can be highly variable across different organizations. But you can receive this reimbursement and then use it to put back into your operation. So this is in comparison, for example, to the IPP grant that Swamini mentioned earlier, Incentive Payment Plan grant. That is a pure grant from the managed care plan that you can use to support your infrastructure enhancement.
Thank you. And Frank mentioned, as well as Tessa in her presentation, mentioned that there are these hubs that are emerging. So there are centralized organizations that are providing some of the complex back office functions and paperwork, and also have more experience working with managed care plans than maybe every single service provider might. Chris, you are looking to using one of these kinds of models and expanding your footprint. What do you see to be the benefits from a managed care plan to work through a hub model? And then maybe Swamini, you can talk a little bit more about these hub approaches.
Yeah, I think I'll just say, a lot of the biggest challenges I think has kind of been mentioned, with working with local housing organizations that they were new to Medi-Cal, right? And so contracting with a health plan, billing claims, that's like, foreign territory for a lot of these organizations. So we, I think we have some hub models set up in some of our counties where maybe the local county government entity is kind of taking on that hub model and kind of at their like kind of local geographic level. And we're seeing some great examples in some of our counties, Los Angeles and San Francisco. And, so I think those are, and, the county government contracts with the network of organizations in the community to do that, which is wonderful. And I think, so there's different models that we have, maybe it's a county entity playing that role, and or like what MidPenn is doing, where they're contracting directly with us as a health plan. But then I think we're also kind of how we got connected to Jamboree, in the last several months, is that we're also finalizing our contract to bring on Housing for Health Orange County, which had a really robust model in Orange County with the health plan there, and a strong network. And I remember talking with them, and I was like, wow, okay, this is interesting. Like, like how could we, do this across some of our, Anthem's counties and, I think particularly I was really interested in their model because, again, they take on all the heavily administrative kind of burdensome stuff that most housing organizations are like, I don't want to deal with any of that. I provide the services, I know the best practices, right? And all the other stuff, oh, it's a headache. And so we really we're also thinking about it in some of our rural counties in California, right? Where we have some really great smaller, like local housing nonprofits, but that they're providing, outreach services, they're doing running shelter programs, they're doing supportive housing, but the CalAIM kind of billing was always like, it's just not something we can do. So, we're talking with Housing for Health Orange County to kind of serve as a hub for all of our counties, but really looking at some of those rural counties where, again, great organizations, but the contracting piece really difficult for some of these. So, we're exploring that. We're going to be launching some services with the Housing Community Supports and using that nonprofit hub model, while continuing to also, work with our local county government agencies on some of their hub models and continue to contract directly with organizations if that's the route they want to go. So kind of having various options, that we can make available.
Great, thank you. And Flamini, you've really seen it evolve from, this is a demonstration project. So when it started, nobody had any experience doing this. And now we're a few years in. What would you say to a new organization? Would you say, see if there's a hub in your county? Would you say, reach out to a managed care plan and first ask them whether or not they provide community supports? How would you, somebody putting their toe in the water for the first time, how would you suggest they do this?
Great question, Carolina. I think the most important piece is the organization needs to figure out what their skill set is. If it's community supports, ECM, and figure that out. Reaching out to the managed care plan early on definitely is advisable because you'll get to know the nuances of the managed care plan and how you need to set up systems. I would say if you were to consider directly contracting or a hub model, you need to understand your administrative bench. Do you have an information technology department? Do you have a data analytics department? Do you have a department that will help you with your CRM platform that does documentation and helps you bill for services? If you don't, a hub model may be a good answer for you because the hub has figured that out with the specific managed care plan that you would be partnering with. So that might get you off the ground sooner. There are obviously pros to doing it all in-house because you find efficiencies of scale. Everybody gets to understand the nuances and what can we do better. We can scale to different counties because we are able to standardize resources, just like Daniel pointed out, tools, documents, checklists and stuff. It is definitely a partnership and a program worthy of considerations. Your readiness assessment is critical. What will it take for you to go from meeting with the managed care plan to sending your first claim? What does that length look like? How's your leadership vision and support for it for a long-term scalability? Because even with IPP funding, every health plan will ask you, what's your sustainability plan? Because the resource is not meant to be forever. So how would you develop it? So I think if you have those pieces figured out, it helps you take the next steps forward. Taking the first step is important because if you are, it would be overwhelming to just know of all of these things to do, and taking the first step is important. So your managed care plan partnership and your skill set and what you want to focus on and your resources in-house would definitely help you figure that out.
Great, thank you. Frank, I know that one of the things that you have focused on and MidPenn has as well is the importance of staff training and making sure that staff are well prepared to provide these services. Can you talk a little bit about sort of the staff training component and that interaction with residents?
Yeah, so going back to the hub model with HHOC, one of the benefits from that is they do bring that standardized element of the paperwork and all the documentation, which helps us with our training. So when new staff comes in, we're onboarding, we have all that information ready to go for them so we can provide that information for them. And they stabilize the the billing part, so we won't kind of have to worry that, but we do get an idea from them because we meet with them weekly in the
You meet
collaborative.
with the hub staff weekly or with your
Yeah.
own staff?
With the hub staff, and then obviously they give us updates, so that goes back to our staff being trained on any updates from CalOptima or any information coming through. Because in the big picture of things, having somebody under a hub model is great because as a collaboration, we can understand everything standardized. But for the staff, it's important for them to know the process that we're going through, and knowing about the ratio for 1 to 20 clients is important because this is the benefits of us getting reimbursement, whatever it may be. But they do provide some information for trainings as they're onboarding for HHOC. But for us as an organization, it allows us to continue to provide that information for our staff. What we usually do is me and another staff member of ours, we provide like a monthly training, a CalOptima. It's basically an A through Z intake paperwork, how to use this, how to look at the SIN numbers, everything that you need to know to continue to work with them, but also bring scenarios of what's going on so we can kind of guide them in that standard. We also provide big pictures trainings like trauma informed. We just did one yesterday. So it's part of the ongoing process because we want our staff to be knowledgeable in the things we do. We have a saying that what is it? We're building the plane as we fly it. But we want them to be in the point where they're comfortable. Everybody knows how to do case management, but the structure that CalAIM is providing for us, it's a really big picture. We want to make sure they understand the process they're doing. So we try to do trainings at least quarterly, provide information. We have CalAIM manager meetings so we can kind of go out over the updates so we can go to our staff. It's an ongoing process, but I think as our staff has grown because of CalAIM, we are looking for HHC to guide us in some of the trainings, but we also provide our own trainings as well.
Great, thank you. And Danielle, you've said that this, even if there wasn't CalAIM, the work that you've done to try and expand access to supportive services for your residents through the lens of partnerships with MCPs has actually sort of strengthened your systems and your ability to provide person-centered care. Could you talk about that a little bit?
Yeah, I mean, I think, and I see in the Q&A, there's, questions about the future of CalAIM, and as was mentioned, we're in a demonstration waiver, so we're here through 2026, and we'll see what is to come. But I think regardless of what happens, the infrastructure that we've been able to build through our CalAIM journey has really created lasting value and contributed to some positive changes for our organization. We have strengthened our data systems. We have learned a lot about HIPAA and enhanced HIPAA compliance. We've streamlined operations because we directly contract with our managed care plan partners and we handle the claims management process in-house. We've also been able to develop standardized workflows. We've increased automation with our systems. There's been a lot of cross-departmental collaboration with our IT and data analytics team, with our legal team. And these didn't necessarily exist before, or these relationships weren't as strong before. So I think these are, long-lasting kind of foundational improvements, which elevates our organization's capacity overall. On the service provision side, I would say I think our team members that are implementing and HTSS feel really connected to the residents. They feel like there is value in intentionally checking in, even in permanent supportive housing. And in fact, with CalAIM and with HTSS, services are optional. The residents don't have to engage with us, right? But we want them to engage with us. And so having more intentional service provision, creating care plans for all of our participants, and really going back to this person-centered approach, how are they progressing on their goals? I think our team has found a lot of value with that in establishing relationships and kind of contributing to and helping to foster a sense of efficacy amongst our participants as well.
Great. And yeah, you brought up the big elephant in the room, right? We're facing a lot of possible policy shifts, including cuts to Medicaid at the federal level, the possibility of the waiver expiring at the end of 2026. There's also other developments happening in this space. Assemblymember Wicks and Stefani have also introduced AB 804, which would turn the community supports and housing support services into a benefit. DHCS is also in the process of finishing their final transitional rent rule, which might be released later this month. So there's a lot of policy shifts and uncertainties that we're not going to be able to answer here. We don't have a crystal ball, but we encourage you to continue to pay attention to those policy shifts, but also these partnerships between housing and healthcare organizations are critical. And so don't let that policy uncertainty stop you from stepping in. We're running close to time. And I do want to end with a wrap-up question for everybody, which is, what's a success story that highlights the benefits of trying to overcome these implementation barriers and really using this partnership between housing and health to support people experiencing homelessness? And Frank, I'm going to start with you.
Great, thank you. I think the one success story I would always say is when I first started the program. Obviously, I've done case management, homeless services, and with children, DV, everything my whole life. And I usually kind of had an idea of when I'm working with a person, like, this person really needs the services. When I was working at a treatment facility, when we started working the program, I met a young lady who came here, who was on came here. It was a DV situation, mental health. And when I first started talking about the program, she was from another country. Obviously, she didn't not understand what was going on, and she just seemed like she was deflated. She didn't want to do this. CalAIM provided me that structure to talk to her about it, kind of work with her. And little by little, all the aspects from CalAIM supported her to the point where she was able to find therapy, find assistance, find housing, find the stability, and it allowed us to continue to stay and work with her to the point where now she's housed, she has a job, she goes to school, and she doesn't need our services anymore. It's been 2 years, and she's progressed from being lost and being alone in this country to being within her community and supported. And if it wasn't for the CalAIM program allowing us to stay with her that long and provide these services, deposit, ECM, all of that, I think it wouldn't have worked. But that's one of the best success stories I can see, because I went from thinking this is not going to work out to her proving me wrong and showing that it did work.
Thank you. Danielle?
Yeah, I think there's been a lot of really meaningful and impactful outcomes that we've seen so far. I think our resident stories, capture that impact most meaningfully. I'll quickly share, a colleague of mine shared this story the other day about a resident at one of our communities that was really struggling. He had a hearing impairment, was not communicating or engaging with property management or the on-site services team. There was a sense of isolation and behavioral challenges, health challenges that were, posing threats to their continued tenancy. We were able to enroll this resident in our HTSS program, connect them to a case manager, and that communication gap was effectively bridged. So through HTSS, this resident was able to access medical and dental care. They were able to get IHSS support, other supportive services that were really meeting his needs, and over time has started to engage more with property management, being more proactive when there's issues with their unit. He's more independent, he's more confident, he's more comfortable. And so I think that just underscores, the fact that this work is hard, and yes, there is promise and there is value in doing this work and helping our residents not only just stay housed, but thrive in their housing, right? Really integrate into their community. And so that's why, we're excited to continue to forge ahead despite the administrative burden, despite the challenges that come up, really in service of our residents.
Chris?
Yeah, I think I'm excited just to see more supportive housing units come online, and seeing the partnerships between, housing, the housing sector, homeless service agencies, developers, right, with health plans. Just last week, one of our Anthem staff got to make some remarks at a grand opening of a home key development in Tulare County, and 22 units, like beautiful supportive housing units that our members are moving into. And this is, I think you mentioned RH Community Builders, I think earlier in the presentation, and they're serving as both the owner, operator, developer, right, but also as the CS and enhanced care management provider. And so it's a great partnership, and we're excited to see more of these things kind of come online in coming months and coming years. So yeah.
So maybe one quick.
Yes, I will highlight the case conference collaboration that has happened. We've had a resident who was struggling with mental health and physical health challenges in supportive housing and needed a higher level of care placement. If it was not for CalAIM, we wouldn't have a ECM manager working with the resident, with our team, to help figure out what's the best level of care. And then going to resident choice, we worked with the resident for over 3 to 4 months to meet him where he is at, to help him understand why is the new level of care a better placement. Had it not been for CalAIM, it would have been an eviction, or it would have been continuous hospitalizations because the resident was in an inappropriate level of care for his needs. So CalAIM, I think the overall wraparound resources and services definitely works, and it takes a village, definitely.
Thank you all. Thank you, everybody, for joining us. Please stay tuned for the case studies that are going to dig into some of these issues in more detail. And yes, please follow up. We will try and answer the questions in the chat in those various case studies that will be coming out through the rest of the summer. Thank you, panelists. You guys were amazing. Thanks, everybody, for joining us, and have a great day.